Chapter 8. Neurodegeneration associated with cardiovascular disorder and role of Ayurvedic management. Recently, it has been established that cardiovascular disorders is strongly associated with neurodegeneration. As inflammatory process is identical in both our cardiovascular and neurological system simultaneously. Several factors responsible for neurodegenerative disorders and cardiovascular disorder. Inflammatory and hyperhomocystinemia are common risk factors for the manifestation of above clinical conditions. There is evidence to implicate He increases following oxidative stress which resulting in DNA damage, triggering of apoptosis and excitotoxicity. The above process is responsible for all important mechanisms in neurodegeneration, Matson, et al., 2003, and cardiovascular disorders, Wall, et al., 1980. Elevated levels of inflammatory cytokines in Alzheimer's and Parkinson's diseases, particularly tumor necrosis factor, TNF, and interleukin IA, that have shown significant association with the above clinical condition. Further, the high level of inflammatory marker CRP is also an important risk factor for the development of neurodegenerative disorders. Thus, the prevention of neurodegeneration is based on the regulation and control of inflammatory process among the elderly people. The agents like ApoE for hyperhomocystinemia, environmental toxins and infectious agents also play an important role in the etiopathogenesis of neurodegeneration. The inflammation is responsible for increasing free radical reactive oxygen, ROS, species and nitrogen, ultimately, resulting in death of neuronal cells. The level of reactive oxygen species, ROS, increases with age. These inflammatory cytokines bound to the cell membrane, turns on transduction system which leads to genetic transcription, gene activation and the production of nitric oxide synthase. The rate-limiting enzymes for nitric oxide and also for COX-2 enzyme causes increased inflammation, Schmidt 2002. The individual, who receives nonsteroidal anti-inflammatory agent substantially, is noticed to have a reduced risk of onset of neurodegenerative disorder. The inflammatory markers interleukin I and TNF-alpha can be measured in substantia nigra among Parkinson's brain, Chen et al. 2003. Diabetes mellitus and neurodegenerative disorders. Diabetes enhances the risk of neurodegenerative disorders. Diabetes has shown an adverse effect on the hippocampus, the area of memory processing, and thus, increases the risk of Alzheimer's. Demonstrated that hippocampus is damaged by glucose. Therefore, glycosylated end product amyloid is important. Amyloid is a protein that is actively produced in the brain under the influence of specific enzymes. It is metabolically active protein which markedly increases the inflammation in the brain. Mitochondrial dysfunction reduces adenosine triphosphate, ATP, production and ultimately, leads to calcium influx. Mitochondrial dysfunction is also responsible for enhancing the cytokine production which increases nitric oxide production and further resulting in mitochondrial damage. Thus, a number of factors like genetic, xenobiotic, metabolic, vital endotoxic drugs cause mitochondrial oxidative damage leading to activation of mitochondria. Due to mitochondrial damage, production of ATP is significantly reduced resulting in brain dysfunction. Parkinson's and Alzheimer's diseases are the resultant effect of mitochondriopathies. Diabetes mellitus is an independent risk factor for CHD, increasing risk by 2 to 4 times for men and women, respectively, Hafner et al. 1998, Grundy et al. 1999. CHD is a leading cause of death among diabetics, and approximately 25% of myocardial infarction survivors have diabetics, National Cholesterol Education Program 1994, Grundy et al. 1999. Recently, American Heart Association in their scientific statement has described diabetes as a cardiovascular disease, Grundy et al. 1999. Abnormalities of glucose metabolism are particularly common and important in Asian Indians and often occur without significant obesity, Makega et al. 1993, Abate, Shandalia 2001, Anand et al. 2000. A recent study in India has indicated an age-standardized prevalence of diabetes and impaired glucose tolerance of 12.1% and 14%, respectively, with no gender difference. Ramachandran et al. 2001. Both diabetes and impaired glucose tolerance are associated with increased risk of CAD even within the ranges considered normal. Pius et al. 1996, Ka et al. 2001. Approximately 80% of deaths in diabetic patients are attributable to cardiovascular disease, which in turn is highly correlated to dyslipidemia. Keefe et al. 1999. Diabetic dyslipidemia consists of elevated triglycerides, low HDL and an increased proportion of small dense LDL. Homocysteine is basically a mitochondrial toxin, causes influx of calcium, and it also metabolizes the homocysteic acid, which is a direct mitochondrial poison. Drugs that reduces vitamin B, and folic acid are enhancing the homocysteine levels, and thus, the risk of Alzheimer's and Parkinson's disease is significantly increased. Muller et al. 2004, Shashadri et al. 2002. Excess fat enhances the production of cytokines. Body fat acts as a reservoir for toxins and neurotoxins. Thus, the dietary regulations have a profound effect on inflammatory process and also on transcription of genes. A substance, docosahexaenoic acids, DHA, play a significant role in mitochondrial and called arachidonic acid is derived from animal fat, which enhances inflammation, neuronal membrane fluidity, signal transduction, neurogenesis, gliogenesis, synaptogenesis. It reduces COX-2 enzyme and thus, reduces inflammation. Hypertension, dyslipidemia, obesity, menopause and type 2 diabetes are the currently available data suggests the strong correlation between significantly associated with high inflammatory markers, elevated level of atherogenic lipid profile and hyperhomocysteinemia. Therefore, there is direct evidence that the management above cardiac risk factors also responsible for neurodegeneration, particularly senile dementia of Alzheimer's type and Parkinson's disease. Therefore, it is not out of place to refer the importance of these clinical conditions as basis of unless the above underlined etiological factors are corrected, the management of neurodegeneration is incomplete. At the beginning of 20th century, cardiovascular disease accounted worldwide for less than 10% of all deaths. At its end, cardiovascular disease accounted for nearly half of all deaths in the developed world and 25% in the developing world. By 2020, cardiovascular disease will claim 25 million deaths annually, and CHD will surpass infectious disease as the world's #1 cause of death and disability. Recent etiological analysis of major cardiovascular risk factor and mortality demonstrated high correlation between expected and observed mortality rates for the three main risk factors, viz., tobacco smoking, serum cholesterol, and hypertension. The cardiovascular risk factors are similar for both sexes, but men develop CHD 10 to 15 years earlier than women. Grundy et al. 1998. The incidence and prevalence of CHD increase sharply with age. CHD incidence rate in men are similar to those women in the cases of 10 years older. Castelli 1984. Approximately 52% women and 46% men will eventually die of atherosclerotic disease. Tom et al. 1987. Increased pulse pressure, systolic blood pressure caused by age-related arterial stiffening are powerful predictors for myocardial infarction and death. The treatment of systolic hypertension even among very old patients reduces risk for death, stroke and CHD. Franklin et al. 1990, Shep Cooperative Research Group 1991. Physical inactivity and atherogenic diet are considered leading factor to cause death. McGinnis et al. 1993. Epidemiologic data indicate that population with diet high in cholesterol and animal fats have high prevalence of CHD. Kestelet et al. 1993. Keys 1980. Strong dose-response relationship between tobacco smoking and CHD has been observed in both sex group, in both the young, elderly, and in all racial groups. U.S. Department of Health and Human Service 1983. Further, tobacco smoking acts synergistically with other risk factors for CHD, which leads to high mortality and morbidity due to massive infarction and stroke. Grundy et al. 1990, O'Kinney et al. 1997. Smokers have shown increased level of oxidized LDL. Smoking also lowers the cardioprotective levels of HDL. This directly affects on carbon monoxide and nicotine production, leading to endothelial damage and increases the vascular reactivity. Free et al. 1991, Sellermoger et al. 1993. Tobacco smoking is also related to increased level of fibrinogen and platelet aggregation. Rival et al. 1987. Several studies have shown high plasma fibrinogen level associated with future risk of cardiovascular disease, myocardial infarction and stroke. Cannell et al. 1987, Thompson et al. 1995, Ma et al. 1999, Ernst et al. 1993. Menopause, natural or surgical, is associated with increased CHD risk due to estrogen deficiency. Belchitz 1994. Menopause syndrome generally associated with hypertension, obesity, and dyslipidemia. According to the National Ambulatory Medical Care Survey, there were more than 1,000 million clinic visits related to hypertension. Woodwell 1997. According to WHO Expert Committee, 1996, hypertension remains to be a common and serious problem, contributing in a major way to the most common causes of morbidity and mortality in developed societies. Studies among women have shown that they tolerate hypertension better than men and have lower coronary mortality rates. Barrett Connor, 1997. South Asians have a higher level of blood pressure than the whites in USA. Gillum 1996. Hypertension is a major independent risk factor for CHD. Roberts 1995, Keyes 1980, and also associated with vascular dementia and neurodegeneration. The prevention of neurodegeneration is based on the regulation of systolic and diastolic blood pressure within normal limit, 140 mm of mercury. Vanden Heugen et al. 2000, Cannell 1996. Several epidemiologic studies have demonstrated that both systolic and diastolic hypertension have a strong, positive, continuous and graded relationship to CHD. McMahon et al. 1990, Collins et al. 1994. The potential mechanisms by which hypertension may cause coronary events include impaired endothelial function, increased endothelial permeability, lipoproteins, and increased adherence of leukocytes, increased oxidative stress and myocardial wall stress. Franklin et al. 1999. Blood pressure elevation is a common concomitant of obesity. Berkeutold et al. 1983, Stamler et al. 1975, Tobian 1978. A relationship between weight gain and increased blood pressure is well documented by Johnson, Cannell et al. 1967. Hypertension is approximately 3 times more common in obese than normal weight person. Van Italy 1985. In hypertensive patients, weight reduction reduces blood pressure, which is associated with decreased blood volume, cardiac output and sympathetic activity. Oberman et al. 1967. Tyroler et al. 1975, Ryson et al. 1978, 1983. Obesity is defined as a condition of excess body fat which has occurred because energy intake is not matched by energy expenditure, resulting in a positive energy balance. Adverse consequences of obesity have been known since the time of Hippocrates. Obesity in youth is the major healthcare challenge for the 21st century. Obesity is common health conditions and their prevalence is increasing globally. WHO 1997, 1989, Popkin et al. 1997. More than 50% of the U.S. adult population is overweight or obese according to the criteria of the National Heart, Lung and Blood Institute, 1998. Unfortunately, there has been a phenomenal increase in the prevalence of obesity in India, particularly in the urban areas. Several studies have suggested that the relative risk of mortality associated with increased BMI is greater among younger women than older women. Liu et al. 1979, Lindstedt et al. 1997, Stevens et al. 1998, Kaye et al. 1999, Bender et al. 1999. Obesity is a risk factor for a wide range of disease and is associated with increased morbidity and reduced life expectancy. Several studies have examined childhood and adolescence obesity associated with psychological and social factors related to premature death in adulthood. Nieto et al. 1992, Dipietral et al. 1994, Manson et al. 1995, Gunnell et al. 1998, Rosengren et al. 1999, Yarnell et al. 2000, Engelen 2003. Epidemiologic studies have shown a strong association between socioeconomic status and the prevalence of obesity. This relationship is much stronger in women, Napa et al. 1978, Ross et al. 1983. Epidemiological studies have shown that obesity is associated with marked inflammation, endothelial dysfunction, abnormal lipid profile as well as insulin resistance and hyperleptinemia, and the decreased level of adenoneptine shows the rapid progression of atherosclerotic changes. Hyperhomocystinemia contributes to the formation of atherothrombotic plaques. The rupture of plaques leads to myocardial infarction and death. The endothelial dysfunction produces mild impairment in the brain function which leads to vascular dementia and neurodegeneration. Therefore, the management of neurodegeneration should be based on the management of etiologic factor responsible for neurodegenerative changes. Therefore, the management of obesity and abnormal lipid profile are essential. Several studies have shown that obesity is associated with an increased incidence of cardiovascular disease, type 2 diabetes mellitus, hypertension, stroke, dyslipidemia, osteoarthritis and cancer. They have influenced the mortality and morbidity. Manson et al. 1990, Huang et al. 1997, Tornberg et al. 1994, Schaaf et al. 1998, Kolditz et al. 1990, Manson et al. 1995, Willett et al. 1999, Wideman et al. 1990, Davis et al. 1988, Mann 1974. Accumulated evidence indicates that obesity that occurs at an earlier age has a greater influence on cardiovascular disease. Ostfeld et al. 1975. The effect of obesity on cardiovascular disease has generally involved with other risk factors such as hypertension, diabetes and dyslipidemia. Sidney et al. 1987, Keyes 1976. Joint National Committee on Prevention, Evaluation and Treatment of High Blood Pressure, 1997, defined obesity as the major risk factor for cardiovascular disease and associated mortality. Weight loss improves insulin sensitivity and glucose disposal reduces HbA and HbC. In persons with type 2 diabetes, reduced blood pressure and triglycerides produces a modest reduction in LDL and increased HDL cholesterol. Numerous studies show that the pattern of body fat distribution affects morbidity and mortality from cardiovascular disease. Bouchard et al. 1990, Donahue et al. 1987, Dussanetier et al. 1989, Lapidus et al. 1984. Many studies have demonstrated the beneficial effects of weight reduction on cardiovascular risk factors such as hypertension and dyslipidemia. Ricin et al. 1983, Scherer et al. 1991, De Simone et al. 1992, Rossner et al. 1987, Zimmerman et al. 1984. Treatment of obesity should be based on its severity in the presence of comorbidities e.g. congestive heart failure, dyslipidemia, hypertension, non-insulin-dependent diabetes and obstructive sleep apnea. It is commonly known that excess calorie intake, physical inactivity and abnormal concentrations of biochemical markers leads to obesity. This condition is also associated with coronary risk events. Therefore, the management of obesity is an important step for prevention of neurodegeneration. Pharmacological intervention for obesity includes several appetite-suppressing drugs which induces weight loss by influencing central nervous system receptors associated with eating and appetite regulation. Noradrenergic, amphetamines, and serotonergic, fenfluramines, agents are widely used for decreasing hunger and increasing safety. Bray et al. 1999. Two medications, sibutramine and orlistat, are currently approved by the FDA for long-term use in obesity management. Lean 1997, Bray et al. 1997, Rolls et al. 1998, Hansen et al. 1999, Hill et al. 1999, Hollander et al. 1998. Appetite-reducing drugs are not safe, and the long-term use of these drugs may cause mood fluctuation, cardiovascular excitation, and selective effect on certain neurotransmitters, mainly on catecholamines. Graddock 1978, Evans et al. 1975, Sullivan et al. 1978, Brennett et al. 1993, Abenhain et al. 1996, Bowen et al. 1997. It is reported that almost all the CHD risk factors are associated with an inflammatory process and also simultaneously resulting in neurodegeneration, due to limitations of the pharmacological intervention for essential hypertension, dyslipidemia, and obesity. In the present study, the hydroalcoholic extract of Dioscorea bulbifera and Hippophae rhamnoids has been evaluated for the prevention and management of various risk factors associated with CHD and neurodegenerative disorder. As mentioned earlier, the dyslipidemia is the consequence of endothelial dysfunction due to enhanced inflammatory cytokines. Therefore, it is essential to manage all those associated factors responsible for the above-mentioned risk factor for CHD and neurodegeneration. Elevated serum total cholesterol and low serum HDL-C are major independent risk factors for CHD, Grundy et al. 1999. Epidemiologic observations, angiographic studies and lipid-lowering trials, as well as experimental studies, confirm the importance of LDL-C as a cause of atherosclerosis in both men and women with or without symptoms of CHD, Grundy et al. 1990, Wood et al. 1978. An elevated LDL-C level appears to be the primary CHD risk factor. The higher LDL-C levels, greater risk of an atherosclerotic event, Grundy et al. 1997, 1990. A strongly positive linear relation exists between serum cholesterol levels and CHD worldwide, Roberts 1995, Keyes 1980, Wood et al. 1978. A low level of HDL-C is a potent individual predictor for CHD in population in which average cholesterol levels are relatively high, but it may not hold as a predictor in populations in which mean level of serum total cholesterol is low, Grundy et al. 1990. Although high LDL-C is the primary lipid risk factor, other lipid parameters increases the risk of CHD in persons with or without an elevated LDL-C, specifically, the combination of elevated concentration of triglycerides, small dense LDL and low levels of HDL-C is referred to as atherogenic dyslipidemia, Grundy 1998. Most patients with atherogenic dyslipidemia have a generalized metabolic disorder called Syndrome X. Recent studies strongly suggest that elevated serum triglycerides are an independent risk factor for CHD, Hokanson et al. 1996, Assman et al. 1998. The data reported have clearly identified hypertriglyceridemia as a risk factor for CHD, Wood et al. 1998. Further, several evidences supports this concept that LDL is the primary atherogenic risk factor for CHD. Accordingly, the National Cholesterol Education Program, 1994, has identified LDL cholesterol is the primary target of lipid-lowering therapy. 5 decades of research on the role of LDL in the pathogenesis of CHD represents one of the major advances in modern medicine and public health, Grundy 1999. Hypertriglyceridemia, low level of HDL-C and hypercholesterolemia associated with obesity are the major risk factors for CHD, Albrink 1974, Olevsky et al. 1974, Bagdade et al. 1967, Yari et al. 1971, Cannell 1979. Among the numerous recognized risk factors for the development of atherosclerosis, one of the best documented is the association between blood lipid and coronary artery disease, Inter-Society Commission for Heart Disease Resources in 1970. The evidence of the association between serum cholesterol level and coronary artery disease is extensive and unequivocal, National Heart, Lung and Blood Institute 1977, Cannell et al. 1979. Several cross-control studies have been demonstrated that high triglycerides level associated with coronary risk factors, Albrink et al. 1961, Carlson 1960, Rifkin 1968. In sharp contrast, evidence from several studies clearly establishes that the risk of coronary heart disease is directly related to the concentration of plasma cholesterol, Keyes 1970, Cannell et al. 1971, Kinch et al. 1963. In spite of numerous studies in the past that demonstrated the inverse relationship between HDLC and atherosclerosis, HDLC is only now becoming part of a standard coronary risk profile, Gordon et al. 1977. They have shown that in both men and women older than the age of 50 years, HDLC has the strongest relationship with CHD. They have recommended that HDLC should be included into the risk profile for coronary heart disease, together with LDL and VLDL. As a molecule, LDL is approximately 50% cholesterol by weight. Thus, a patient with an elevated level of LDL is usually expected to have an increased level of cholesterol. By this property, LDL-C is directly associated with coronary artery disease, Fredrickson and Levy 1972, Stone et al. 1974, Rhodes et al. 1976. Lipoprotein A consists of an LDL particle linked via a disulfide bond to an apolipoprotein A polypeptide chain. High plasma concentration of lipoprotein A identifies persons at increased risk of ischemic heart disease, Nielsen 1999, Scannon 1998. Several case control studies support the view that lipoprotein A is independent risk factors for thrombotic disease, Ridker et al. 1993, Schaefer et al. 1994, Wald et al. 1994, Ridker et al. 1995, Compton et al. 1998, Wild et al. 1997. Fibric acids, nicotinic acids and niacin improve the lipoprotein pattern in patients with atherogenic dyslipidemia. The above drugs have shown several side effects, therefore its application is limited. Tate et al. 1998, Stahls et al. 1998, Vega et al. 1994. Inflammation plays an important role in the initiation and progression of atherosclerosis, Ross 1999, and systemic blood markers of inflammation such as CRP, serum amyloid A, and fibrinogen have emerged as powerful predictors of coronary events, Danish et al. 1998, Lagrand et al. 1999, in asymptomatic men and women, Ridker et al. 1997, 1998, in patients with stable and unstable angina and after infarction, Thompson et al. 1995, Liuzzo et al. 1994, Toss et al. 1997, Morrow et al. 1998, Ridker et al. 1998. C-reactive protein is a hepatically derived marker of low-grade systemic inflammation that largely reflects circulating cytokine function. Several large-scale prospective studies have shown the inflammatory marker, the high-sensitive CRP, a potent predictor of future myocardial infarction, stroke and peripheral vascular occlusion among apparently healthy men and women as well as among high-risk smokers and the elderly person, Ridker et al. 1998, 1997, Koenig et al. 1999, Culler et al. 1996, Tracy et al. 1997. Levels of high CRP are also elevated among those with acute coronary syndromes at high risk for recurrent events and among post-myocardial infarction patients at high risk for recurrent instability, Liuzzo et al. 1994, Morrow et al. 1998, Ridker 1998, Riffai et al. 1998. Several systemic hemostatic factors, including fibrinogen and platelets, have been identified as determinants of future CHD events, Mead et al. 1998, Maresca et al. 1999. Oxidative modification of LDL has been hypothesized to play a major role in the initiation and progression of atherosclerosis, Steinberg et al. 1998. Increased dietary intake of antioxidants such as vitamins E, C, and beta-carotene may associate with reduced cardiovascular risk, Greenberg et al. 1996. Numerous retrospective case control studies have identified mild to moderate hyperhomocystinemia as a strong and independent risk factor for CHD, stroke, and peripheral vascular disease, Bauchi et al. 1995, Robinson et al. 1998, Refsum et al. 1998, Molyneux et al. 1999, and a clear association between plasma homocysteine and the anatomic extent of carotid, coronary and aortic studies, Stamfer et al. 1992, Arneson et al. 1995. Many studies demonstrate that elevated homocysteine has a strong predictor of cardiovascular disease, Culler et al. 1998, Cattaneo 1999. Materials and methods. In this study, 137 diagnosed elderly cases of dyslipidemia with age range of 60 to 72 years were selected to evaluate the role of an Ayurvedic formulation in the prevention and management of abnormal lipid profile with an object to prevent the neurodegeneration among elderly people associated with multiple CHD risk factors. Under this study, the elderly people who exhibited high body mass index, BMI, with high level of total cholesterol, LDL-C, and triglycerides along with low level of HDL-C but no cardiac involvement were treated with Ayurvedic test formulation containing the hydroalcoholic extract of Dioscorea bulbifera in the dose of 450 mg per day, and Hippophae rhamnoids in the dose of 500 mg per day, twice in a day. Before using the test drug for human consumption, the toxicity profile was carried out in animal studies. No significant allergic, gastrointestinal, hepatic, renal, hematopoietic and reproductive toxicity were observed. The formulation did not show any mutagenic or carcinogenic potential in the preclinical studies. The hypolipidemic effects of the test formulation were carried out in high cholesterol diet-induced animal models. After preliminary screening of the elderly subjects, a baseline recording of the lipid profile including triglycerides and various pro-inflammatory biomarkers were estimated among the selected subjects. In selected subjects only plasma, homocysteine samples were measured. Lipid profile including triglycerides and lipoprotein, A, were measured utilizing standard laboratory kits. Plasma homocysteine, TNFA, and interleukin-6 were estimated by ELISA kit method. CRP was determined by utilizing kit for quantitative nephelometric determination of CRP in human serum of plasma Turbox/Turbox analyzer. ELISA and activity assay kit for leptin was used for leptin level estimation. Mini-mental state examination was applied among all the elderly dyslipidemic subjects under study to assess the effect of test formulation on their neuropsychological status. After baseline recording of the parameters, 78 elderly subjects were orally administered the test formulation as per day schedule continuously for 6 months. In other group, 59 dyslipidemic elderly patients were kept of placebo treatment to compare the results. Both groups of dyslipidemia cases were advised a calorie-restricted diet, 1,000 to 1,500 calories/day according to the body weight. The test was repeated at the end of 3 and 6 months. The baseline values of the parameters were compared with the values obtained at the end of 6 months and students' paired t-test was applied to compare the results. Method of preparation of test formulation: the hydromethanolic, 30 to 70, extracts of Dioscorea bulbifera, 450 mg per day, and Hippophae rhamnoids, 500 mg per day, which were concealed in empty capsule, 500 mg, with the help of an additional additive were given to the elderly dyslipidemia subjects for 6 months. The test drug capsules were prepared according to 2 divided doses per day, i.e. 1 capsule morning and 1 evening. Placebo capsules were prepared similar to test drug and given for same duration and schedule. 2 follow-up studies were carried out at the end of 3 months and 6 months in both series. The data obtained were statistically analyzed. Observations and results: it is observed that high BMI was associated with high leptin level along with elevated lipid. In treated group, BMI and leptin significantly reduced in comparison with placebo group after 6 months of therapy. In placebo series, BMI and leptin also showed declining trend but statistically insignificant. This change may be due management of obesity, Table 1, to dietary control. This change indicates the beneficial role of test drug in the test formulation has reduced the lipid profile, exhibited its potential effect in reducing the total cholesterol, LDL-C, triglycerides and lipoprotein, significantly, whereas placebo series cases have not shown much reduction in the levels. The difference in the basal values versus 6 months treatment values were significant in test drug-treated group. A moderate increase in HDL-C indicates the prevention from atherogenic injury following therapy, Table 2.6. In the present study, the pro-inflammatory markers like CRP, interleukin-6 and TNF-A showed decreasing trend following oral administration of Ayurvedic. The inflammatory markers, Table 7.9. Test formulation. In placebo group, subject could not demonstrate any change on. In initial study, high level of homocysteine were observed in both groups. Following 6 months of test drug treatment, a significant decrease in the homocysteine level shows the importance in cardiac function by improving the intima medial thickening and thus, minimizing the future cardiac event, Table 10. Mini-mental state examination of the elderly group showed improvement after 6 months of therapy among elderly dyslipidemia group. The test drug has shown